I was addicted to drugs for 32 years. I didn't live a normal life from the time I was 15 to almost 48.
Hannah did pass away of an overdose. There was a large amount of carfentanil in her system.
Everybody has a story. There's always a reason for an addiction. An addiction is never because somebody chooses it.
I see them and they're a person, and they're somebody's son, daughter, husband, wife, child who is suffering and struggling and doesn't want to be living this way.
First wave of opioid challenges in our community came probably in the early 2000s, maybe 2001, 2002.
In Sault Ste. Marie in the Algoma district, 52 people died from an opioid overdose, and that's not including other addictions, alcohol, other substances.
Mostly what we were seeing before was in sort of the field of alcohol, or with alcohol use. Alcohol continues to be a major problem in the community and elsewhere. What's really escalated in the last, I would say, 5 years or so is opiate use in the community. That has a lot to do with the availability of fentanyl and analogs of fentanyl that are now available, and the most available substance next to alcohol in this community.
She was a just beautiful person inside and out. And then about 9, we noticed something changing. At the age of 9, she started getting very angry. So I kept an eye on it, and she started not wanting to do things with the family. And so by the age of 11, one of the teachers at elementary school she went to had came to me and said Hannah was cutting herself. At 12 at least, she was using marijuana. 100%, because she wasn't getting the medication. So she was self-medicating.
My addiction started with a pain problem when the morphine stopped working and I upgraded to heroin. In my case, I started smoking it in cigarettes because I was 15. And I met a boyfriend who taught me how to make heroin. And I made and sold heroin. And then I started injecting it. And once I knew how to make it, no one had to know my secret because I didn't have to go anywhere to get any. I had a baby on heroin and nobody knew. I worked, I went to school, I looked, acted normal. Nobody had any idea. As somebody who was addicted to heroin, I went to a doctor and told them that I had addiction to heroin because of the pain that I was in. And his solution was to put me on OxyContin. And then my addiction spiraled from the treatment of the pain. The whole start of this was from chronic pain, which I now know was actually a bone disease. Being addicted to an opiate takes over your life. And you forget what it was like to live without the opiate.
I think we've been working to address or do our part of addressing the opioid crisis for many years now. I think what we're doing that's unique, not only for the hospital, but for our community, is we're functioning very well right now, very closely with community partners. So there's a larger group that has really come together to do some much needed, impressive work when we see walk-in counseling available. You see the community wellness bus, the 137 East Street residents working together that, as I mentioned earlier, no one agency can pull that off on their own, whether with or without funding, but doing it together, then you end up with that shared expertise, knowledge exchange, sustainability, and really you can help more people with different needs.
Making sure that all those different programs communicate and work so that the patient has a very positive experience. That's why we are working so diligently to address that, because it is a really devastating illness and affects, whole families and whole communities at a very deep level.
The RAM clinic is a rapid access addiction medicine clinic. Clients will come in, and if they're struggling for alcohol use disorder or opiate use disorder or any other substance use disorder as a whole, then we meet with the client and develop treatment goals. We offer medicine that can help them along their path to recovery and support them along the way.
Here at the clinic, a typical day or appointment would be you're coming in, you're meeting with the RPN, which is Christine, and myself to kind of determine what you need treatment-wise. So whether that means that you're meeting with our nurse practitioner, Gary Lynn, or you're meeting with one of our physicians. And then that's not just for opioid use disorders. We also work with clients who are struggling with alcohol as well. So that's basically whatever you need. We'll kind of create those pathways to get you where you need to go.
If you have a doctor, then they can refer you to RAM, or even if you don't, it's a self-referral program. So anybody can call us and let the clerical staff know that they're interested in seeking services. They will then end up talking with myself, and we do just a little bit of triaging. I ask some more questions just to get a better history of the client and to build that rapport from the beginning. And then the day that they'll meet the doctor is they'll come into our office and they'll meet with the doctor or the nurse practitioner. Typically the first day of the appointment, we always make them aware that it is going to be the longest time that they'll be in the clinic. It's usually about an hour.
There's a pretty extensive intake, sort of getting a general history, because although addiction is a portion of things, it's not the entire person, obviously. So getting a sense of that, where the barriers may be, where the strengths are, all of that. And then at the end of that appointment, there's a discussion about what we have to offer. Does that fit their needs?
After that, we'll have subsequent appointments for follow-up. Usually they'll have a follow-up every week. And as progress goes and they're meeting their milestones and they're getting more stabilized and into maintenance phases, then their follow-ups may be every month.
A lot of the medications required for addictions or anything are very expensive. And then the transportation and the arrangements getting to and from treatment centers is also a large barrier. Because then it's not just the individual going away. They have to make plans for their pets, their children, their family. It's a lot of steps to go through for someone who's in a fragile state.
If they don't have a health card, then we really will make sure that we can support them in getting a health card number established, because they will need a health card number to be able to go to the pharmacy and get their medication. I think the benefit that we provide to our client is that they always know that there's somebody here. They know that Christine's around in the clinic and you can call, and yes, we're open Monday through Friday. We're not here on weekends, but they do know how they can access services over the weekend if they need anything. They know that they can be at our doorstep Monday morning if something happened, and we will be there to open the door and say, come on in.
We're not only just offering addiction services, we're also offering that counseling, that brief motivation, that connection to community resources, a connection to a nurse practitioner and an RPN.
As an agency, we want to help, and it's up to the client what that looks like. Come in and even have a conversation or call and say, what do you do there? This is my situation. Can you do anything to help? Things like that. I guess just it's important that people know that we're here and we want to help.
I'm just an advocate. I'm just here to help them along the way, and they're the ones that are making the change, and watching them come out on top and go to treatment and get the help that they need. That's the most successful part and the rewarding part for me.
Whether they hit 1 month of recovery or we've now gotten over a year, it is the most rewarding part of my job, and it's the reason why I'm here.
I come to counseling once a month, or I see the Christine once a month, and I do tests to make sure that I'm staying on track. I discuss any issues. I thought they were great here. I found these people cared. It was one-on-one.
With Hannah, the RAM clinic was amazing with her. She used the services in the community. Don't be afraid to call and get these services for your children because they're there for a reason.
It's really important for people to understand about addictions counseling is it's different for every single person. People come to us at different stages. So whether you're just starting to think about making a change or you've already made a change and you want to go back and work on the reasons that drove the initial change, that's going to be really individual. Our addictions counseling service is actually really easy to access. Of course, you can refer a family member, a doctor might refer you, a detox, a peer, but you can also just call us. What are the areas that you need to work on? So for some people, it might be really just education about addiction and early skills to either reduce a behavior or eliminate it. Others, it might be really talking about some past trauma or family of origin issues. We might go as far as communication skills, interpersonal relationship skills, goal setting. It's really varied, right? And there's a lot of misconceptions and a lot of fear when you're coming to counseling that you may need to lay everything out on the line to a stranger. And it doesn't have to be that. It can be if you want someone to sit with you through that. But it's really about you coming to us and showing us what it is you need right now at this stage. And that's what we'll work on.
In the day treatment program, that's a very new program. So those clients are concurrent disordered, which means they have severe addiction and also a mental health together. And I do a lot of the group therapy within that program, as well I do some individual therapy for the clients within that program as well. Most of our clients have said they really like it because you get to come, you get to learn skills, you get structure to your day, but then you go home to your life. You don't have to leave your kids for a month to go to treatment. If you work at night, you can still keep that job. We have a harm reduction approach. So if I use on Sunday night, you can still come back to group on Monday morning, right? Or if I'm still withdrawing or if I'm still tapering off my opiate, I can still come to group and do that, whereas other treatment centers have very strict and rigid rules around that, which is fine. But we have provided the flexibility for you to make more than one mistake and continue to come back for care. I think that's the biggest thing that clients have said, is that it's just a much more accessible model and they feel not judged and cared for and like they can keep trying. The biopsychosocial model looks at all the different factors in a person's life that would lead them to struggle. So we think about the biology, like what maybe you're born with, what you've inherited. So we know some mental health disorders like bipolar or schizophrenia, and sometimes depression runs in the line. If you also have physical ailments, right, that can make it harder for you to function. The psychology would be our mental health issues and symptoms of mental health disorders. And then the social piece is the stuff about housing and having access to food and access to work and access to meaningful relationships. The whole person, yeah. We don't just treat one part of it. For the day treatment program, you need to be referred. You can self-refer. You have to have a moderate to severe addiction, and you have to have a mental health diagnosis as well.
Currently, when individuals are referred to a new day, to the day treatment program, I reach out to them to do some screening and make sure it's the right fit for them. So we're looking for individuals who are living with both mental illness and moderate to severe substance misuse, and also that they're contemplating change. So they're looking towards making a change in their pattern of substance misuse and looking for some support to do that. Once we've decided that they are a good fit for the program, we start working through the assessments and such.
Because we work in concurrent disorders, so I deal with addiction and I deal with mental health at the same time always. So part of counseling is helping the client reach their goals. So sometimes in addictions counseling, that's just harm reduction, getting my use to where I can function. I'm not necessarily interested in stopping that. Sometimes addictions counseling is really doing some sort of helping with functioning, so getting housing, getting food, how am I gonna, get my kids to school, that kind of stuff. And often addictions counseling, which is the piece that I really like to work towards, is going after the trauma or the thing that brought you to addiction in the first place. So it's a kind of a whole piece. Once someone's stabilized and their addictions were a place they feel it's manageable, then we try to also deal with the trauma that brought you there in the first place, or deal with an untreated mental health issue that probably brought you there in the first place.
In working with addictions, there's often a small window of time when people feel like they're ready, willing, and able to make a move toward change. And sometimes the system isn't ready to catch them. Some of the wait lists have been frustrating. The other challenge would be addiction itself. We're offering a program that will support people who are ready to make some change with regards to their substance misuse patterns. We're offering breakfast and lunch, hydration. We're offering recreation. We have some art therapy opportunity, and mindfulness, cognitive behavioral therapy, dialectical behavioral therapy, and it's a large commitment. It's 4 to 6 weeks of programming, 5 days a week. There's opportunity for individual counseling. I'm available for case management-y stuff, making sure that referrals are made if people would like to continue with more programming, or if they have more psychosocial needs like housing or food security, court issues, all kinds of things. Really trying to meet people where they're at and really support them to get onto the next stage, the next process for change.
I meet with clients in the community. It's a new program that we have for people who may not have done well in detox traditionally. Residential treatment may not be an option for them. People in the community who've maybe never had success with detox or have never been identified by us before as having addictions issues. So people who've been drinking a long time and functioning well, professionals who maybe don't want to come to the hospital, people who don't want to leave their dogs. So we're looking at non-traditional options to help people in their homes, meet them where they're at. There are certain criteria that a patient has to meet in order to withdraw at home, and we determine that through an assessment. Patients who can withdraw at home, we're offering an option that's never existed in our community. So that's really great. A lot of people don't want to go the traditional route. And here we are offering them something in the safety and comfort of their own home with their support systems while also treating their addiction. We also meet with people who have been discharged from the hospital, who've been detoxed already in hospital, and we're kind of just bridging the gap between the actual detox process and a treatment facility, because that can be a long wait sometimes. So I do weekly visits. Sometimes I'll do it more often, daily, if somebody will be withdrawing at home. We're going to work with family doctors to make sure people have the medications they need, to make sure it's a safe process. The second half of my job is I work the community wellness bus. It's a new initiative with the hospital and a lot of partner agencies in Sault Ste. Marie. And I visit 5 different sites in the community where we've identified a lot of addictions, mental health needs. So again, we are meeting people where they're at. They don't have to come to us at the hospital. So we have social workers, we have anti-trafficking workers, we have Canadian mental health peer support workers. We have myself, so I do a lot of wound care, primary care, referrals, housing referrals, basically whatever people need. And sometimes all they need is just someone to talk to. We have a lot of issues that we're not going to solve overnight, but we're there to listen. We've been pretty effective in getting patients connected with the resources they need that have always been available, but it's hard to piece that puzzle together, especially when you're dealing with everything that comes with addiction. Now you're newly detoxed, it's hard to cope with big changes, and so we're kind of there to guide them, support them, and make the connections they've never made before. So far, it has been pretty effective. We've had a couple patients do better so far than they ever have.
The addiction medicine consult team is largely concerned with stabilizing people in an acute care setting. The mandate of the team is to assist other physicians and providers in the hospital with the aspects of care that are directly related to the addiction that any given patient is struggling with. People who are using intravenous drugs and in the community are often getting severe infections in their skin, infections in their bones, infections in their heart, sometimes traveling to lungs, and they end up very ill and require a lot of medical care in order to stabilize their medical health.
So we can get referrals through Emerge, through Crisis, or any inpatient unit in the hospital. So we'll get a referral through Meditech, and then we will decide if we go together as the RN and the addiction service worker, or if we can go separately depending on what the needs are based on the referral that we get. At that point, we would introduce ourselves to the patient, explain our role, what we can offer them, see if they're interested in what our program is all about, explain our program, and then that's where we would start helping them with medication or start their treatment plan.
The rewarding part of the job is to be able to intervene with people, to see people stabilize and some people get better in recovery. That gives me a pretty good feeling when I see that. It's a slow process in many ways. It's a gradual process, but watching a person steadily improve is a great thing.
Residential withdrawal management is a healthcare setting in which persons 16 or older who are experiencing either acute intoxication or acute withdrawals, so they're withdrawing from any particular substance, can get support through those withdrawals. And then once they've reached the other end of those withdrawals, or the withdrawals are manageable, they can then seek support for treatment planning if they so choose. It's different from residential treatment in that residential withdrawal management is short-term. Typically, you're looking at a 5 to 7 day stay, depending on our program. The treatment process at withdrawal management involves first stabilization. So whether someone comes in and they're intoxicated, we obviously want to help them reach a point of sobriety first, and we expect there to be withdrawals afterwards. So then we're going to stabilize them and help support them through those withdrawals. Whether that's just providing comfort measures like extra blankets, showers, just a compassionate ear, what have you, will provide those supports. In addition, the nurses are able to provide comfort medications such as Tylenol, ibuprofen, Gravol, Imodium, and those types of things. We also provide nicotine replacement therapy as well for while they're here. So we go through that stabilization piece. Once stabilized, then we're looking at treatment planning based on what the client's goals are. If they're not ready for change yet, if they're not interested in abstinence or cessation of substances, we'll provide health teaching about harm reduction. We have naloxone kits available, and our staff are trained to provide that training to our clients, and then we can actually dispense those naloxone kits, which is wonderful, and that's new for us. As we all know, naloxone kits save lives, so that's a wonderful piece that we're able to provide. If someone is actually interested in treatment or looking at options, even if it's something just they're not quite ready to stop their substances, but they are looking for some support, so they're pre-contemplative at this point, or contemplative, we can look at referrals to, say, the RAM clinic or the addictions treatment clinic. We can look at referrals to a new day program, which is a day treatment program. So that's outpatient. It's a Monday to Friday program, which is wonderful if someone's not ready to commit to a lengthier residential treatment program.
When clients come to the withdrawal management program, first I say it's a self-referral program, so anybody is welcome provided we have beds available. Sometimes people access those beds through the emergency department. Sometimes it's a referral from the RAM clinic or one of the other addiction-focused clinics in town, or from their family members or from their family physicians. At withdrawal management, we're fortunate enough to have some safe beds, which are beds that are allocated for people who need a little bit longer period of time in a safe environment.
Mental health, addictions, legal problems, trouble with the law, police, frequent encounters with the police, housing, if they're chronically homeless or something. The Safe Ed program being up to 30 days, and you could really change your whole life in 30 days. Try and get some stability in some of these most vulnerable people.
I've had clients tell me that it's amazing how non-judgmental and open you guys are. Just having someone there to listen to their story and have someone to talk to and understand and listen and be empathetic, I think that's really important.
I would say one of the more challenging parts of our role in withdrawal management, even in mental health and addictions in general, is you can do everything you can to provide support to a person. You can set up everything in terms of treatment planning. You can provide them with all the resources and tools that they need. But at the end of the day, their progress, their outcome is going to be dependent on their readiness to change and where they're at on that continuum of change. So we may see, despite all these efforts and hard work that we've put into helping get a patient set up for success, they might not be ready. And it's challenging to learn to accept that someone might not be ready for change yet.
I think we do everything we can every day, and we need to stay on that. So to address the crisis, we need to keep working with our partners. We need to keep working with the patients and families that are impacted directly every day.
There are so many great programs in this community. There are so many fantastic clinicians going above and beyond every day to meet the needs of this community, and I see us working together on the common goal of really supporting people and building up our community.
The ultimate goal would be we are able to house as many of our mental health and addiction service-related programs under one roof at the new site.
In many ways, the work is partway through. So it's certainly not in its beginning phases, but we know that as the needs change, we'll need to continue to respond to that, be, if anything, ahead of it. So as we're able to catch up and care for the needs of our community members, and then look to see how we will enhance it. We're making good progress. It really is one large step, one large foot in front of another at this point. We'll continue to do that. It's good work that we have in progress. We just need to continue on with it.
It doesn't matter where you come from. It doesn't matter who you are. You could come from millions of dollars. You could come from nothing. Drugs, they do not discriminate. Mental health does not discriminate.
The fight is not over in terms of addictions within our community and addiction services within our community. We have an amazing, dedicated team who are constantly looking at reevaluating and improving the services we have to offer. But as mentioned, it's a community approach, and things that the community can do is just be supportive, be non-judgmental for those persons who are suffering from a substance use disorder. We really all have to work together if we want to see improvement in this area. We need everybody's help.